The evidence base for endovascular stenting, primarily endovascular aneurysm repair (EVAR) for abdominal aortic aneurysms, that is AAA, and thoracic endovascular aortic repair (TEVAR) for thoracic aneurysms have evolved through several landmark randomized controlled trials. While endovascular technique offers clear perioperative advantages, long-term data highlights a catch-up phenomenon in mortality and higher burden of re-interventions compared to open surgical repair. Four major randomized controlled trials, EVAR-1, DREAM, OVER, and ACE, form the backbone of the evidence for treating infrarenal abdominal aortic aneurysms. All major trials demonstrated a significant reduction in 30-day perioperative mortality with EVAR compared to open surgical repair. Beyond 2 to 3 years, the initial survival benefit of EVAR disappears. Long-term follow-up up to 15 years in EVAR-1 shows that all-cause mortality becomes identical between the two groups. This is largely due to late aneurysm-related deaths in EVAR group, often from secondary ruptures or complications. EVAR is associated with a significantly higher rate of re-interventions compared to open surgical repair, primarily to manage endoleaks, graft migration, or limb occlusion. The evidence for TEVAR in thoracic aortic aneurysms is primarily based on prospective registries and the GO-TAG pivotal trial and GORE conformable TAG thoracic endoprosthesis (CTAG) trial, as RCTs comparing TEVAR to open surgical repair are limited due to the high morbidity of open thoracic surgery. TEVAR is now considered the first-line treatment for descending thoracic aortic aneurysms. It reduces perioperative mortality and significantly lowers the risk of paraplegia and respiratory failure. Evidence supports intervention at a diameter of 5.5 cm or more for TEVAR in the descending aorta, though individual risk factors and growth rates more than 1 cm per year also trigger repair. The 2024 European Society for Vascular Surgery guidelines provide the most contemporary synthesis of evidence. Open surgical repair is recommended as the first choice treatment for fit younger patients, example age less than 70, with a long life expectancy due to its superior long-term durability. EVAR is preferred for older, frailer patients or those with significant comorbidities. But EVAR-2 trial, which is the only RCT evaluating frail patients not suitable for open surgical repair, concluded that EVAR does not increase overall life expectancy in patients ineligible for open repair, but may reduce aneurysm-related mortality. For juxtarenal or pararenal aneurysms, fenestrated EVAR and branched EVAR are increasingly supported by high-quality registry data showing lower mortality than complex open repair in high-risk patients. Guidelines now strongly recommend that centers perform at least 30 abdominal aortic aneurysm repairs annually, minimum 15 EVAR and 15 open surgical repair to maintain optimal clinical outcomes. The long-term success of endovascular stenting is contingent upon lifelong surveillance to detect Achilles heel issues. Endoleaks. Type 1 and Type 3 require urgent re-intervention to prevent rupture. Type 2 is common and only requires treatment if the aneurysm sac expands. Post-EVAR sac growth is a surrogate marker for failure and a high-risk indicator for late rupture.